Hi guys, today I'm going to talk about ectopic pregnancy, and this is an essential topic as it will definitely come up in exams and you will commonly see patients with ectopic pregnancy on the wards. An ectopic pregnancy is defined as implantation outside the normal uterine cavity, and normally in pregnancy we see that fertilization occurs within the fallopian tube, and cilia will move the embryo down the fallopian tube into the uterus where it implants. And the uterus has a lot of room for the embryo to grow and to form, whereas the fallopian tube does not have this room. So it is not a good place for the embryo to implant. In ectopic pregnancy, this sweeping by the cilia does not happen, so that implantation does not occur in the endometrium. Instead, in ectopic pregnancy, the implantation typically occurs in the fallopian tube, as the cilia have not properly moved the embryo down from the fallopian tube into the endometrium. A small proportion of ectopic pregnancies can occur in the cervix, the abdomen, or even the ovaries themselves. However, 95% of ectopic pregnancies occur within the fallopian tube. Unfortunately, if an ectopic pregnancy does occur, we cannot simply move the pregnancy from the fallopian tube, for instance, into the uterus. So this pregnancy is not viable because an embryo cannot grow in the fallopian tube. It doesn't have the space to, and it's not the correct environment. The danger of ectopic pregnancy is that the pregnancy can progress in that the embryo can grow, but it doesn't have room to grow, and therefore this can lead to rupture of the fallopian tube, and this can be very serious for the mother. So why might an ectopic pregnancy occur? Well, there are a number of risk factors, and most involve the cilia and the movement from the fallopian tube to the endometrius, or the endometrium. So the key risk factors are pelvic inflammatory disease, where there may have been adhesions or inflammation. That means the fallopian tubes aren't as healthy as they should be. Other risk factors include surgery to the fallopian tubes, which can cause damage to them and increase the chance of ectopic pregnancy. Things like smoking reduce the cilia activity, and previous ectopic pregnancies and increased age all predispose and make it more likely for a woman to have ectopic pregnancies. So how will the patient present? Well, they will typically present with abdominal pain, and this is due to stretching of the fallopian tube, and there may be shoulder tip pain, as there could be diaphragmatic irritation due to perhaps a rupture of the ectopic pregnancy and blood moving round the diaphragm or free fluid, and this will cause irritation of the diaphragm and referred pain to the shoulder tip. Sometimes there is vaginal bleeding, but more often than not, bleeding occurs intra-abdominally. Bleeding can occur vaginally in small amounts due to endometrial shedding. And ectopic pregnancy can also lead to hypovolemic shock. And this is because the fallopian tubes receive their blood supply from the ovarian artery, and this is quite a large artery. It's a branch of the aorta and has a significant blood flow. So when an embryo implants in the fallopian tube, It can damage the blood vessels, in particular the ovarian artery, which can lead to significant intra-abdominal bleeding and hypovolemic shock. So you meet a patient, they present to ED department with low abdominal pain, perhaps some PV bleeding, and they're a young female of childbearing age. What investigations would you do to exclude or include ectopic pregnancy? So first of all, you would do a urine beta HCG test, and this will confirm pregnancy if they are in fact pregnant. And another investigation that is very useful is a transvaginal ultrasound, and on this ultrasound you may see an empty uterus, and if they had a positive pregnancy test and an empty uterus, you would be thinking maybe this is ectopic pregnancy, and especially if they had a mass within the anexa, that would point towards ectopic pregnancy. Also, you would need to do serum beta HCG, and to take an initial serum beta HCG and another one 48 hours later. Normally in pregnancy, the beta HCG should double within the first 48 hours, but this is not the case in ectopic pregnancy. Other blood tests should be done, including FBC and group and screen, because there could be significant intra-abdominal bleeding and the patient could go into full hypovolemic shock. You should do a full ABCDE assessment to make sure they're hemodynamically stable. So now you've confirmed ectopic pregnancy, how should this be managed? Well, there are three key ways in which ectopic pregnancy is managed, that is expectant, medical and surgical. So you may consider expectant management, and this is based on the fact that some ectopic pregnancies naturally self-resolve. These patients have very low serum beta HCG, normally less than 1,500 international units, and they're asymptomatic. And you will monitor these ladies' serum beta HCG until the levels are undetectable. Now, most patients are not managed expectantly, but some, if they are asymptomatic and very low beta HCG, this may be an option for them. Another more common option is medical management, and this involves giving methotrexate. This is a folate antagonist, and folate is needed for cell division. So this will affect rapidly dividing cells, such as that in the blastocyte, and this will stop division, and you would need to monitor patients after they receive methotrexate. They normally get a one-off dose, but you would measure the serum beta HCG on day 4 and day 7 to see is it appropriately dropping and will they need a second dose of methotrexate. A third possible option is surgical management, and this should be considered initially instead of medical management if a fetal heartbeat is detected on ultrasound scan, or if the lady is very unstable, if she's in a lot of pain, or if her serum beta HCG is over 5,000. So you can see that serum beta HCG is a very useful test. It helps in our diagnosis and it also helps in our management. Also, if there was an axial mass greater than 35 millimeters on the ultrasound scan, you would be advised to go for a surgical intervention rather than a medical intervention. In surgery, the surgeon will more than likely remove the entire affected fallopian tube. However, if the unaffected tube is not in good condition, the surgeon may only open the affected fallopian tube and remove the ectopic pregnancy. This is not ideal, but it preserves fertility if the lady has a damaged tube on the other side. And any patient who has been surgically treated for ectopic pregnancy should receive anti-D if rhesus negative. And some women are particularly concerned about future pregnancies. Will the ectopic pregnancy reoccur or recur, or will they suffer multiple ectopic pregnancies in the future? And it's important to reassure the women that they can go on to have normal intrauterine pregnancies. However, they are at risk of a second ectopic pregnancy, as having one ectopic pregnancy is a risk factor for having another one, and therefore advise them to get early ultrasound scans in future pregnancies. So this concludes my presentation on ectopic pregnancy. I hope you enjoyed it, and if you did, please don't forget to hit the like button and subscribe for more medical videos.